Dun, 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 dun. Okay, hi everybody. Welcome to today's lecture. I apologize that today has to be a recorded lecture. Certainly not my choice on the way that I would prefer to do it. I'd like to be there seeing all of your smiling faces. But Mother Nature will do what she will do, so here we are. I think it's important we get through this lecture because this is the last one we have before the midterm. So this is all fair game. You can watch the video as many times as you want. I'm not sure many people are going to want to watch it repeatedly, but I am going to put this out there. I apologize. It took me a little longer to get it up today than I thought for some technical issues, but if you're watching this now, that means I got it up. So here's going to be the plan of attack. We'll go through today's material. As I said, anything that we have on here is fair game. I would have liked to have been there because then we could have talked about what's going to be on the exam or any remaining questions you might have now that you've been studying, hopefully, for a week. You may have come across a few things that you wanted to discuss as well. Having said that, I don't think it has to be a fatal issue here. So if you're coming across some questions, I want to suggest a few things. One, I really encourage you to use support groups, study groups, get together, discuss the material, think about it, integrate it, figure out the questions that you have. Two, I want to encourage people, let's use the discussion board. I think that's a great way to ask and answer questions. If there are things that you're stuck on, I am happy to weigh in and give my opinion as well. And three would be to say, if you're really stuck on something, just shoot me an email. I know I'm only on campus, usually on Wednesdays. But having said that, you can always get a hold of me. And if need be, I'm happy to answer your question in whatever way I can. So I can make a slide. I can put it up kind of like this now that I'm better at video capture, whatever it might be. So I hope the studying's going okay. A few reminders about next week's exam. The exam will start right at the beginning of class, so please be ready, be on time, and we'll get going right away. Okay, so it will be done in class, and yeah, I guess that's sort of standard protocol for the exams. The exam is now written. It really fits the model that I gave you last week. And that's kind of what we're going to go for. So if there are questions, let me know. I can post announcements to the class. If there's something that I'm forgetting that you would have been asking me in person right now, I'll put it out in the announcement board so that everybody gets that. For today's lecture, I'm going to go through as if we are doing this together. I'll kind of take you through slide by slide. I've decided in the interest of time and everything else, I'm going to make a few changes to the slides that I actually cover. So it's okay. You have all the notes. I'll take you through, tell you what I'm doing. One of the things that I think is going to be an issue here is I have a number of videos, as I would in class, embedded into the talk. I'm a little bit worried that because if I'm putting this up on YouTube, some of those videos may cause issues and they take down the lecture, which would not be good for any of us. So when we get to the point where there's a video, I will just tell you that there's a video, and I will have posted all of these videos separately on CourseLink. So if you'd like, you can stop, go watch the video, then come back to this, unpause it, and keep going where you're at. Or you can choose to watch it in whatever order you want, I suppose. Having said that, for today's lecture too, I'm kind of just going to plow through it in this session. So the beauty of this is anytime that you're tired of listening to me, you can hit stop and take a break and you come back to it. Or I think you can even listen to me on like 1.5 speed because I don't talk fast enough and you want to hear me even faster or whatever it is. But I hope the video works. I hope this works out. Let's give it a go. So that was actually our first video. I want to skip that really quickly. It's a really good video by a guy named John Oliver. If you're not familiar, he's a talk show host. And he's going over this idea of science and what's science all about. And I'll give you a fair warning. He's kind of snarky, doesn't always use the greatest language. So there's your trigger warning, your content alert. But I actually like the message that he sends. And it's something to think about. How does the media portray science and what we do and how we do it? And this one specifically talks about exercise. So it's a really good one, kind of fits in with what we do. It also fits in with today's topic about dietary supplements. So I have that video posted. You can go back and watch the whole thing. So today we are talking about dietary supplements and talking about ergogenic aids in general. Okay, and I want to just start off by saying, the supplement industry is massive. There's really no better way to describe it. It is a huge and growing industry. Those numbers I'm giving you on the screen now have gone up. There are well more than 600 sport nutrition companies, tons of products, and we're talking billions and billions of dollars, even just in North America. Some of these we've talked about already. I should point out I do have some conflicts of interest. I'm not promoting any brands or anything, but I will talk about some of the research we've done, and of some of the research that goes on at Guelph. Sorry, got to skip that video too because it's probably going to trigger something. Honestly, it was kind of for a laugh, but it pokes at this idea of it's a fake energy drink called Power Thirst. If you want to look it up, it's just kind of a funny video, but I'm not going to post that one. So the whole idea I had there was it talks about like these claims that are made by energy drinks and all these supplements and how great they're going to make you. And I think we can question, is that really the case? So let's go through today. We're going to talk about what are ergogenic aids. We're going to talk about how they're used, who they're used by. And I want to start to pick apart a little bit of like the mechanisms of, should we believe these claims being made? Is it possible that they do what they say they're going to do? And then we're going to use this as a fairly general overview. So I'm going to go through a number of specific ergogenic aids or classes of ergogenic aid and discuss, what's known about them to date. Like many things in the class, my point is not to give you all the information you need to know so you can go memorize it and say, I'm now an expert in ergogenic aids and sports nutrition or whatever. I really want you to be able to use that as a stepping off point. So understanding how a class of drugs or a class of supplements might work and what the mechanisms are, as new things come along that might share similar pathways, for example, we can start to understand and interpret how effective they might be, if they're effective at all, and whether that's something we believe in or would support the use of. So let's start then by defining ergogenic aids. This can be anything, any procedure, agent that enhances energy production, the titration of that energy, or the efficiency for the purposes of sport performance. It thus provides an athlete a competitive edge beyond that which may be obtained through normal training and dietary methods. So eating a healthy diet is not an ergogenic aid. If you're not doing that, you're being foolish. You're expected you should do that. Training is a normal thing to cause adaptation. It's those things that are taking it to the next level. So what types of performance-enhancing substances are there? This is a definition here of what can be sold as a dietary supplement. This is actually from the American side, but I think it's a good way to sort of define these. So a product, other than tobacco, because it has its own sort of classification, that's intended to supplement the diet and contains one or more of the following dietary ingredients would be considered a dietary supplement. Anything that's a vitamin, a mineral, an herb or botanical, amino acid, a dietary substance to increase total dietary intake. So those can be your fillers as well. A concentrate, metabolite, constituent, or extract, so something that's more purified. And the product has to be intended to be eaten and cannot be advertised for use as a conventional food. So it can't be something that just replaces a normal part of the diet. Okay, so we're talking about dietary supplements, things you're going to eat above and beyond, and if it's ergogenic, it's for the specific purpose of getting better at exercise and performance. So today we're going to talk about these nutritional supplements and performance enhancers, but I just want to point out there are all sorts of other types of ergogenic aids. So we can think about things that are mechanical or technological aids. So for example, if we look to the right there, the Under Armour shirt, I suspect most people in the class have heard about compression garments, right? And we can debate, do compression garments work? They're purported to stop the muscle from moving around as much, to change blood perfusion. Truthfully, the most current evidence suggests that compression garments work if you believe they're going to work. And if you don't believe they're going to work, then they tend not to do anything, both for exercise and recovery. That's an interesting one. Suggests it might be a large placebo effect. If you look down below that, triathlete wearing compression socks, it's another thing, slightly different than maybe the ones that are intended to compress muscles close to the core. And it has been suggested that that can also change contraction patterns and efficiency and stuff. Whereas compression socks like that are really intended to increase venous return and cardiac output. I would suggest that as of now, the data does not support the use of such things. It's a neat idea that if we're squeezing extra blood out of the venous side, out of the volume reservoir and back to the heart, that cardiac output could go up. Truth of the matter is, so far the technology isn't there, because if you get enough of a compression to actually squeeze the blood back, as soon as you contract the muscle of the calf, for example, you're actually occluding blood flow. So you're hindered more by the fact that you're not getting blood in than you're aided by getting blood back out. So they tried this with soccer players a few years back, and they were all laying on the turf holding their legs because they're starting to cramp. We can also think about like purely mechanical ergogenic aids. If you're a cycling fan, you've probably seen these things before or heard about them. I mean, when we think cycling and we think cheating, we think about erythropoietin and blood doping. But there's actually now mechanical doping as well, which means, say, if you can see this, this is the front part where the pedals would go off of here. That's the main chain rings. And this is actually a little motor that slips inside the down tube of the bike. And so now they're finding these on the Tour de France and other things as well. I find it really interesting, somewhat unrelated to our class, but it's interesting how like that type of doping, at least to me, seems like that is straight up cheating. And it's not to say that taking EPO is okay, but I don't know, that seems even worse in some weird way. So we can talk about these things: mechanical, technological, pharmacological. I mean, that really gets at, you know, erythropoietin, steroids, using drugs to specifically change things. We can talk about psychological. There's certainly things we can do to change it. I think we take a very physiological approach to things we do, and maybe that's one of the biases that I bring because that's what I'm trained in. But I don't think we can deny that there are things we can do to improve the way we think about exercise, and that may even have physiological effects. And so the physiological ones, I think that's pretty obvious. So let's talk about supplements and the reality of these supplements. There are many quote-unquote claims that the oral supplementation of whatever compound you want to think about will improve sport and exercise performance. So there are claims about things like caffeine and pyruvate. We'll go through a number of these here. The truth of the matter is most of these things have absolutely no chance of altering human physiological function. And the reason is human physiology is regulated, not just tightly controlled in negative feedback loops, for example, but it's often, if it's an important process, it's controlled not just by one controller and one effector. There are usually redundant systems so that if one fails or if they have mixed messages, something else steps in to take over. So I think we need to approach this with our optimistic skepticism, as we've talked about before, right? So we need to think about, okay, if this is the claim being made, whatever it might be, how is that supposed to work? And does that actually make sense? If we pick it apart, could it actually do the things that it says it's doing? So let's walk through kind of a process of how we do that. If we think about these dietary supplements, we need to think about it in this way. This is the order in which things have to happen. You have to eat it, okay? And after you've eaten it, then it has to get into your stomach. And from your stomach, it's going to have to progress into the intestines, okay? So first of all, it's got to be something that you can eat that you can actually, you can swallow, you can chew. It's palatable, I suppose. You don't have to like it, but you got to be able to get it down. And that's saying a lot for some supplements I've seen. The gut has to be able to handle it. There are certain things that cause gastric bleeding. And some of them are actually quite common. And this can be a real issue. And it can absolutely have the opposite effect. It's not going to make you faster, and it's definitely not going to make you healthier, and it can lead to all sorts of problems. So actually a common one that affects the gut that many people don't know about is your non-steroidal anti-inflammatory drugs, right? Ibuprofen is used by a lot of athletes prophylactically with the thinking of, well, I'm going to hurt later, so I'm just going to pop a bunch of this ibuprofen now. We now understand that even if they're enterically coated, they can really affect the gut, and they can cause what we call leaky gut, bleeding in the gut. And my group actually thinks that one of the effects of that leaky gut is obviously it's not good if your gut is bleeding to begin with, but it may also affect like sepsis. And so when you start to initiate that process, we think it's affecting the vasculature, which affects cardiac output, which again works exactly against what you want to do. But it has to get into the gut. It has to not harm the gut. It also has to be absorbed by the gut, okay? And from there, let's say that you were able to eat it, it got into the stomach, okay? You got it into your intestines, it's absorbed, then it has to be transferred into the blood. It has to be circulated in the body. From the circulation, it needs to be perfused into the working muscles or wherever it's having its action. And let's say that it gets to the area that it's causing the action, then whatever change it causes actually has to affect performance. So in this class already, we've talked about a number of things that might get to the tissue. They might cause a change in the molecular soup, if you will. But that doesn't mean just because an enzyme changed or whatever else we were trying to affect, that performance actually goes up. So quite a number of steps, a lot of hurdles that we have to get through. So the question is, does it actually make it through all of these? Is there one of these things that is limiting and is going to stop whatever's being claimed? So what would we like to know? Kind of going through what I suggested there. Is the supplement degraded in the mouth, stomach, or intestine? There are a number of things that saliva, right at the beginning, changes the way it works. Beetroot juice is an interesting one. It's sort of the opposite of what you might think of. Beetroot juice, when they started using it, so beetroot appears to affect efficiency, let's call it. So VO2 max and perhaps your ability to push harder in aerobic exercise. One of the things they realized early on was that in athletes who were using mouthwash, it actually stopped the efficacy of beetroot. And it turns out that there's a bacteria in your mouth, and if you destroy that bacteria, we don't have the conversion that has to happen in your mouth. So there's one thing. Is it degraded by the presence or the absence of something in the body, in the mouth, in the stomach, in the intestines? Does it actually get absorbed into the blood? If it does, is it stored, degraded, or metabolized by the liver? I mean, we have systems that are specifically meant to remove things that shouldn't be there. They can be hard systems to beat. Is it degraded? We need to think about the half-life of these things. So let's say we actually get it in. Let's say the liver doesn't actually clean it and remove it because it views it as bad. How long does it actually stick around? We need to think about, does the kidney remove it? Many of these things are just washed away in our urine. So, vitamins, that's one of those interesting things that seems it's becoming trendy, these vitamin infusions, which don't make any sense to me at all. But when you think about, or people that are even popping, handfuls of multivitamins, you can't store more if they're water soluble. If they're fat soluble, they can actually be dangerous. But your kidney, if they're water soluble, will just say, okay, that's cool, we don't need you. And effectively, all you've accomplished is making expensive urine. Does it accumulate in the blood, and does it interact with the target organ? Big things to fill. And is there an increase in the blood, and how large is it? How long does it last? So all this to say, let's not put the cart before the horse, because there are a lot of hurdles to get over. And this is really what set things up, most things, to actually not work. So we can test all of these things, and we're actually going to go through. If you are watching this with somebody else, I want you to take a second, or even if you're sitting by yourself, I encourage you to do this, because I think this is an important brainstorming session. And here's what I want you to think about. I want you to think about how many potential ergogenic aids you could list. And I want you to list them in certain categories. So I want you to list those that are banned, so things that we know work. And typically, if we know something works, then it's not going to be allowed in competition. So steroids are a good example of something. They're absolutely effective. And for that reason, we view that as cheating, and they're out. Then I want you to take a down step and say, okay, what things can you think of that you're allowed to use and they actually work? So legal and effective. What kind of things can you think of that are sort of run-of-the-mill? Everybody uses them, and or could use them, and they're maybe not that effective. And then what other ones can you think of that are just stupid? So they might actually be performance inhibiting. So I'm going to come up with a list. See how many you can actually get on there. If we have time, maybe we can take this up some other time, or you can debate with your friends. Okay, so I want to take some time and let's go through some of these classes of dietary supplements. So the first one we want to talk about, we've sort of danced around a little bit before in our protein lecture. So essential amino acids. The idea here being essential amino acids, the ones that we can't make, so we need to take in, they can augment muscle protein synthesis and essentially cause greater gains in strength and hypertrophy. Branched chain amino acids certainly falls into that. We've talked about the role of leucine as a key for upregulating our protein synthesis, and we can talk about leucine and variants of that, isoleucine, valine. The idea here that they're the building blocks. So we've essentially taken proteins and we've come down to the basics of it. There are some studies that suggest improved fatigue resistance, but truthfully, many suggest no effect. And I think we really pulled out a lot of that when we talk about what's going on with protein synthesis, in that having these individual components really aren't that helpful. It appears that leucine is a key player. It has to be there, but it has to be there with the rest of the protein things as well. We can talk about HMB. And in fact, there was just a study published this week from our friends at McMaster University looking at this. So HMB, if you're not familiar, is a metabolite of leucine, and it's sort of just a next step down the chain. And it's been believed that HMB can cause people to grow bigger and stronger, and it might also change the way lipolysis occurs as well. Research has been fairly limited. There's a little bit of new stuff coming out now, as I highlight there. But truthfully, of all the stuff I've read, it really doesn't support the use of HMB. It doesn't work for resistance-trained athletes, and it doesn't seem to work any better than a placebo, quite frankly. So there's not a lot of support that works. I think when we take that on whole, there's a strong role for protein, which would not be a supplement. That's just part of a regular diet, and we can change the macronutrients. But breaking it down into these supplements, there doesn't seem to be a lot of support. We can also talk about what we call our nutritional muscle buffers. So beta-alanine is a good example of one. And this is actually one of the few that we use with our athletes here in Guelph as well, some of our runners. Now, beta-alanine is not something we use with all of our athletes. Really, we just use it with athletes that compete in the sport that it might actually help. So when I say a muscle buffer, what I mean is something that can actually change the feelings of fatigue. And it does that by slowing the accumulation of intramuscular pH. So when the athletes we'd use this with would be athletes that run sort of the mid-distance, the really high-intensity, longer duration. So not the guys doing the 60 and the 100-meter. We're talking 400, 800-meter athletes. If you're not a runner, those are incredibly painful events where essentially you come out going as fast as you can and just try to hold on as long as you can before you start tying up. So we know that lactate is the byproduct of glycolysis. So in these glycolytic type events, lactate brings with it these hydrogen ions, and that's going to change pH. If we have something that can kind of sop up that pH and stop that burn and essentially allow the athlete to keep pushing through it, there's a chance that it might actually help them. So as I said, that's one of the few that we actually use with some athletes, and there may be some support for that. Actually, there is some support for that. It is a precursor to carnosine, okay? And that's how that works. Sodium bicarb would be pretty similar as well. Again, it's a buffer. Sodium bicarb is essentially baking soda, right? So bicarb is going to sop up, again, some of those things, and it binds with the CO2, and we're going to affect our pH. There are definite side effects to that. If you can imagine what would happen if you ate a lot of baking soda, or anybody that maybe, I think everybody did this as a kid, where you make a volcano or you make like little pop bottles and stuff explode, where you take bicarb and you mix it with vinegar, because one of the things that comes off of bicarb is CO2. And so you can imagine if you eat a whole lot of something that creates a gas, that can be a real problem in exercising, either at the top end or the bottom end, because it certainly affect GI issues. So originally bicarb kind of fell out of favor, to be honest, because of those side effects. Nowadays, the dosing is done a little bit differently, and it's done at certain times away from competition so that we have the effects when we want them, or in smaller doses as well. The other issue to be aware of in sodium bicarb, sodium, we're talking salts, and it can actually affect fluid retention as well. So it's something we think about that as a potential side effect. Sodium citrate, very similar to the other two as well, a pH buffer, essentially trying to work through the same way by stopping the bad feelings. I totally just spat on my screen, and now it's going backward. There you go. Yes, so there is evidence that suggests it may work at shorter distances, but not longer ones. So I would say those three are kind of listed in the order of efficacy and the amounts that we see them used. L-carnitine is another thing that we can think about. So that's not the same as carnosine, it's carnitine, okay? And so L-carnitine is expected to work by increasing the way our bodies can use fats for energy. So by changing lipid oxidation, it's believed that we can be more efficient. There is also some suggestion that L-carnitine may enhance recovery from exercise. And the whole idea here being that carnitine is supposed to work by transferring fats into the mitochondria to be used for energy. Okay? There's a number of things that work this way, and carnitine is an example of one of those things that can either be sold to athletes to say, well, if you do a distance sport, we know there's a lot of energy in fats, and we know that that's a very efficient way. So we're going to lower the oxygen costs, and we're going to use fats as our source of energy. On the flip side, it's also sold commonly as an energy weight loss supplement. So we'll talk about that a little bit later in the course. But the idea being the marketing that goes with it is, well, hey, you can burn more fat instead of more carbs. And people in their own minds at least sort of relate that to, okay, well, I'm burning fat, so it's got to be a good thing. I'm going to get skinnier. So mixed evidence on that. We actually have a case study on L-carnitine. You have that in your notes. That's going to be one of the things I don't think we're going to get into a lot. So you are not going to be responsible for that on the exam. But just at interest sake, if you want to go through it, I will include those slides that you can go through. Capsaicin is another interesting area. Capsaicin is essentially the active ingredient in hot peppers. There's not a lot of evidence to show that this works, but it is one of those things that in theory does kind of seem like it might have something there. One of the main ideas about how capsaicin may work is actually through catecholamine changes. So we're sending out sort of these stress hormones, and the idea, very similar to L-carnitine, is that we can actually change lipid oxidation. So to be honest, I worked with a company that came to me when I was on the East Coast, and they suggested that they thought this product that they had figured out a way to get the really hot stuff, like super concentrated capsaicin out of peppers, and they had come up with an encapsulation such that it was supposed to make it tolerable to the gut. They asked us to test two things. One was as a weight loss supplement, with the idea being if we're giving people these hot peppers, we're essentially going to ramp up metabolism. And sorry, we weren't giving them hot peppers, we were giving them the extract of these hot peppers. We're going to ramp up metabolism, and thus they would lose more weight over time. We never published this study, but I can tell you guys it's kind of funny now. At the time, it wasn't that funny. But for 12 weeks, we had people who were moderately overweight take these pills on a regular basis. Long story short, it turns out that the encapsulation that was supposed to allow these pills to pass from the gut, like deeper into the gut before they kind of released and then were absorbed, it didn't work all that well. We had a number of people check themselves into the hospital with severe ring of fire and burning gut and diarrhea, and they were not our fans. So we came really close to having to just pull the plug on this study. Aside from that, even with the severe diarrhea, flaming hot diarrhea, it didn't really seem to work. So we did not see a lot of evidence that capsaicin could actually change that. We did look at resting metabolism and other things. The same company suggested to us that this product, through catecholamine-mediated channels, could also change the ability of people to exercise longer and whatever, and thus would be a useful performance tool and possibly a weight loss tool as well. Except the data that they based that on was walking on a treadmill. So as a sports scientist, my first thought was, sure, but who cares? What if we take it up to race intensity? Long story short, if we take it up to closer to VO2 max, something above submax, turns out it doesn't really do much at all. So I personally have not seen a lot of support for that in our own data, and I don't think there's some data out there. It's mixed data, if I'm quite honest with you. I'm fairly skeptical about capsaicin. Creatine is probably something that everybody has heard about. Creatine really came into its own in the 90s. And at the time, it was expected to be an absolute game changer. The way that creatine works is it's going to affect, it really works through the phosphate. Okay, so we know that adenosine triphosphate, ATP, which is the currency of the body, when we break it down, and particularly when we're using the ATP-CP system, we're cleaving that off and turning ATP into adenosine diphosphate. So the way creatine phosphate works is essentially as being a donor of a phosphate. So we're supplying a ready source that when ATP is broken down to ADP, we can regenerate that by taking the phosphate from creatine phosphate, put it back on the ADP to make ATP again, and now we've got energy. Okay? The whole idea here is that we're going to supplement with creatine, and we essentially bring up the content of the muscles. And we can bring it up substantially by about 20%. There does appear to be a saturation limit, and there does appear to be a period of time in which we need to work to get that up. Now, the loading protocols, they originally started with very high loads that you took in sort of this loading dose at the beginning until you started to pee it out. And it was believed that you really had to hit the body hard with this. We now understand you can get to the same levels of creatine buildup more slowly over time by just taking smaller doses. But there is sort of this loading period before we see optimal effects. Creatine does seem to work. One of the big things that one of the big concerns when creatine came out was, is this safe over the long term? It appeared to be quite safe in the short term. I feel pretty confident saying it's been around long enough and it's widely used enough that it does seem to be safe for long-term use as well. At least we haven't seen any evidence that it's not. So creatine is one of those few that I kind of go, yeah, that works. One of the frustrating things with creatine, I guess, is that we can't change the stores. So that 20% seems to be kind of set. Training doesn't seem to affect that, but it does have a role for certain. So just to show you, here's one study that was done. You can see here they compared creatine use with a placebo, and this was done using squatting. So maximal strength, 1RM squat strength in a Division I football team in the States. And what they did here is they ingested creatine or this placebo, and they actually also looked at it to see if they could combine creatine with beta-alanine, which is kind of a neat idea. So remind you, beta-alanine is one of those muscle buffers. So they said, okay, if we give them creatine, that should allow them to recover more quickly, okay, regenerate that ADP into ATP. And well, what if we also allow them to work out like a little longer and harder because they're not getting the burn as early? And you can see there, it doesn't seem to be an effect such that creatine got any better when we added beta-alanine to it. So creatine supplementation, creatine monohydrate is the most commonly used. It has been shown to increase strength for sure, improve training by reducing fatigue, enhancing post-workout recovery. So we know that it takes, about a minute at least for that to happen. So if we're talking high intensity, repeated bouts, whether that be training in workouts or if you're doing a sport that requires those types of intermittent sprints, it does appear that there's a role. There are certainly pros and cons of creatine use that we can discuss. And some of those being things like pros being that it works for sure. We have this store that we can dip into. It's readily available. Some of the cons for anybody that's used it, I'm sure you're aware of this. When we start storing more intramuscular creatine, water is going to follow it because we've changed the oncotic balance. So fluid retention can certainly be one of those things. When we think about the athletes that we want to use this with, excuse me, it's probably a select group. So there's some athletes that carrying around a little bit more water and having more mass, that's not a big deal. So if you're doing a sport where it's non-weight bearing, for example, it's a pure power sport, it probably makes sense. You probably should be using creatine. When I look at athletes like some of the runners we work with, the sprinters, again, it might make sense. It might also make sense to periodize this at a certain time in their training where we really want to maximize those gains, and then we can worry about getting leaner and faster later. But one of the challenges we have is, would we ever use this with like a marathon runner, for example? I mean, it's possible that you recover a little bit better from a punchy hill, or somebody makes a break and you've got to be able to follow, or the sprint to the finish, or whatever it might be. But when we weigh that against the cost of carrying the extra water weight everywhere, it's pretty hard to justify. So here comes another Burrism, another story, but I think this is an interesting one to tell you about. A few years ago, we were approached by this company, Delivra, and you can see I put up their product there. They make a bunch of them, this Live Sport line of products. Essentially what this group of chemists, they were chemists that work at a university, and they broke off and made their own company. And I believe the backstory was this professor's wife sadly had cancer, and he noted that a lot of the treatment options for her pain were insufficient. And so he just kind of went, I can do better. And so he came up with a way to deliver drugs through the skin. So a transdermal drug process. As it turns out, it was pretty effective. And they went, you know what, if we can deliver certain pharmacological treatments this way, we can probably deliver a whole lot of other things. So a transdermal or transcutaneous cream is really, it's about making things soluble so you can get them through the dermal layer and then into where you want them to act. Long story short, they came to us and said, hey, we've got this idea where we think we can bind creatine to our delivery product and we can get it into the muscle. And we went, well, that's kind of a neat idea. Because if we go back to some of the cons, like carrying extra water weight, what if we could actually rub a cream on the skin and we could force it into only the muscles where we want it? Because once you get it into the muscle, once it's bound behind the membrane, then it's not going anywhere. So once you phosphorylate it, you're good. The challenge when we eat things is you have to eat them. And as we talked about, it's got to get through the gut and everything. And creatine does that pretty well, but then it circulates systemically. So it's going to get into the blood and you can't really control where it goes. So if you're an athlete that only needs this let's say in your legs, runners are a good example, or cyclists, right? There may be a benefit to having that in your legs, but it's also going to go to your arms, and the oncotic pressure is going to change, and you're going to carry fluid there, and that's doing nothing to help you. So we thought, well, this could be a neat idea. So we've actually now run 2 studies. I don't want to say too much because we are working to publish these. Long story short, the company, I want to point out that they are chemists. They're not sports scientists, and they came to us with this pretty package and went, yeah, this is the thing, just rub it on your legs and let's see what happens. And knowing what we know, we kind of went, that doesn't seem very likely that you could put it on and 15 minutes later you're going to be great, but sure, we'll try it. So not surprisingly, there does not appear to be an acute effect of using creatine and trying to force it through immediately. We also looked at that and said, okay, well, what if we use higher doses? What if we rub it on repeatedly? And what if we load it the same way that we would load an ingested creatine? There may be some evidence that there might be a sex-dependent change, quite frankly. I think it's a small change if it's a real change, and I'm not 100% positive that it's a thing. We also tried using this to top up creatine stores as well. So I pointed out that when we ingest creatine, we can get muscle levels up about 20%. We've seen that through biopsy studies. We went, well, okay, can we ice the cake a little bit more? If you're already taking creatine, can we bump that up in specific muscles a little more than that? Evidence is mixed. So I don't think this is going to be a panacea. I don't expect that this is going to be the next big thing, but it's a neat idea, and you can kind of see where people are going. So we've also started to explore, can we package other things with this? There doesn't seem to be, from the evidence looking at ingested creatine and beta-alanine, any point of combining those two, but does it change when we start to target muscles specifically? And are there other things that are small enough to actually force through the skin? So neat idea. So as I talked about, efficacy, yes, it does seem to work. Okay, body mass changes are a thing. If you're going to carry around water, you're going to get heavier. Okay, so you can kind of picture people that sort of get that puffy look. Adverse effects, controlled studies have been unable to document any significant side effects from creatine supplementation. So there is some concern that maybe it's affecting the liver, maybe it's affecting the kidneys because you've got to pee some of this out. Does not appear that that's an issue. And as I said, it doesn't appear that over time these things seem to accumulate, at least from the data we have now. One of my favorites, caffeine. I'm actually sitting here drinking coffee as I'm talking to you now. You should too. It's the greatest thing ever invented. So caffeine, most of us think about coffee is the way we'd get it. And certainly that's the most common way. You can see I've put up a picture there. You can also take it in pill form, and you can get fairly extreme doses that way, I guess. You can get very high doses. The picture of the French fries, this recently came out. You can now get powdered caffeine that you can just sprinkle onto your power foods, like fries. But does caffeine work as an ergogenic aid? This is another one of those things that does seem to work, quite frankly. Caffeine has an interesting history in sports. It's been an allowed substance. It's been a banned substance. It's now back to being allowed. But there are limits on what you can use. There are probably limits on what you should want to use anyways. The long story short is that if you're getting your caffeine through coffee, it's pretty hard to overdose. You'd have to drink a lot of coffee. But if you're taking a more concentrated version, it could start to get dangerous. And it could start to get to those levels where really you're like doping, you're cheating. But caffeine, even in low doses, in quite low doses, does seem to work. Okay, it works by increasing time to exhaustion. There is some evidence that suggests, similar to the way capsaicin was expected to work, it works through catecholamine-mediated effects. There's also some evidence that suggests it may work in different ways as well. And it's working through the brain and basically changing the way the brain feels and how you feel about the exercise. The majority of the work suggests that it works for aerobic type exercise. So kind of getting into the pain cave and just keeping going. The effects on sprint and power, I would say they're unclear at best. There has been a lot of recent work looking at like Red Bull and Monster Energy type drinks. I wouldn't say that any of that is particularly compelling. It doesn't appear that that's what we're limited by, because motivation is pretty easy for that short period of time, and the pathways through which it should work are different. Adverse effects if you take too much, there certainly can be some. Anybody here that's ever over-caffeinated themselves knows all about this. So anxiety can certainly be one. It can be very tough on the gut. It can lead to sleeping issues at night and restlessness. If you're drinking enough that you're starting to get tremors, like the shakes, that should probably tell you something. But caffeine, one of the challenges when you take in too much caffeine is it actually, it does affect muscle contraction. So I know myself, if I drink too much coffee, I get like the eye jimmies where, you know, you're like blinking and you can't stop and it's going really, really fast. And you feel like everybody that you're talking to can see that your eye is freaking out, even though they probably can't because it's a tiny little twitch. But what happens there is essentially caffeine causes the release of calcium. And we know that calcium is related to muscle contractions and it's one of the triggers. So when we have calcium floating around, we've got these issues. It can affect other muscles other than skeletal muscles. Certainly heart arrhythmia can be an issue. You can feel skip beats and stuff. So if you're drinking that much, you shouldn't, okay? It does increase the risk for heat illness as well. It can, particularly in high doses, as a diuretic. So if we are losing water, then our ability to maintain cardiac output and sweating and all that great stuff we talked about last class is going to be an issue. It is physically addictive. Again, if you're a coffee drinker, I don't need to tell you all about that. So key points. Coffee, caffeine, central nervous system stimulant. Okay, it's an ergogenic aid that does have some pretty strong evidence to support performance in aerobic and anaerobic athletes. I will put this video up online, but that is a video from Dr. Lawrence Spreet, who I've talked a fair bit about in this class. He literally wrote the book on caffeine. Like he has a textbook about caffeine and exercise. So that's put out by Nestle. It's a really good video that kind of takes us through what's going on. So maybe stop, take a second. You can find that on course link where we have that up there, and let's go through that. Okay, let's move on to different classes of drugs. So we kind of started to tiptoe into this a little bit because we're going to talk about stimulants, and certainly caffeine can be that. But I want to talk about sort of more powerful stimulants as well. Ephedrine is something that it's a very powerful stimulant, and it's been used quite a bit. I think it's actually on the decline now, and part of that relates to some of the adverse effects that have happened with this. Ephedrine used to be found in many over-the-counter cold and flu things. So Sudafed used to be one of them. If you used to walk, probably 10 years ago now, you used to walk into an NHL dressing room, everybody had a cold, right? They're popping Sudafed. And they might not have even known why or how it worked, but it was really ephedrine. So ephedrine was put in there because it makes you feel better when you have a cold because it opens up your airways and it kind of clears your head and it gets your heart going a little bit faster and allows better perfusion, which all could affect the way that we perform an exercise as well. There was a pretty high-profile Canadian case with this, a Canadian rower. Her name is Silken Lawman, maybe a little bit older for most of you guys to remember. But she had an issue with this where she had been taking Sudafed and tested positive. Claims she didn't know. I mean, who knows? But nowadays, you don't actually find that. It's been removed from many of those over-the-counter medications. You can still get ephedrine. So here's what we know about it. As suggested, it may work. I mean, we used to put it in Sudafed for a reason. Okay, the effect would primarily be for aerobic type performance, because if it's increasing heart rate and it's changing the way we can breathe and it's changing the way we can perfuse muscles by making blood pressure go up, it also may affect our brain. That makes sense, right? Because those are all circulatory driven type things. There's some evidence to suggest it's only effective when we take it in combination with caffeine, and that's typically how people would take it. So we've got these stimulants that we're putting together, and we're basically jacking up everything. We're making metabolism go up, and we're forcing blood through to where we want it. Why are we seeing it going away? It does have a lot of adverse effects, death being one of them, which is typically something we try to avoid for ourselves and our athletes. That's why it has been banned by most governing bodies. Okay, so the IOC, WADA, it is on the banned list. A number of years ago, there were issues, particularly in college football training camps. So we talked about this a little bit before, but that's a really dangerous time for those athletes because many of them are coming back not quite in game shape. So they're deconditioned. They're exercising commonly in twice-a-day practices. It's the hottest time of the year. They're wearing equipment. You add to that some of these athletes were taking things like ephedrine, and it did result in deaths. So heat strain leads to dehydration. Cardiac output can't be maintained. We have all sorts of things. And you put on top of that if stroke volume is going down because plasma volume is going down, the heart is beating faster to try and compensate for that to keep cardiac output out, and then you rev up the whole system, crank up blood pressure, it really just starts this cycle. So the biggest concern would be cardiovascular. Another stimulant was fairly common for a while. It is basically an ephedra substitute. It's called citrus aurantium. Okay, you'll also see it put out there as a weight loss tool, and ephedra has been included in some of those as well, because when you consider if we're really jacking up metabolism, what are we doing? Well, we're burning more calories because there's a cost to the body moving like that. There can also be a cost because we know that sustained hypertension is not good, for example. How is this supposed to work? Well, from an athlete point of view, if it cranks up metabolism and it might also suppress appetite and change the way we break down fats, that could be a good thing. So essentially you're getting bigger, leaner, and you might feel better during the exercise for the same reasons as I talked about with ephedra. Again, combination with caffeine would be common, and it might improve things like time to fatigue or performance on a time trial, but it does come with risks. As a result, it is also banned by the NCAA and other bodies. Okay, so I encourage you to do this. Again, we would normally hand this in class, but since we're not there together, I guess we won't. But here's the idea I want you to go through. So imagine your friend has approached you with a new workout supplement, and it's combining creatine, which we talked about, and caffeine. So it's called creatine, which sounds like a wonderful thing. And your friend asks you to invest as a partner in this new venture. So you're going to take this to market. What do you think? It's 2 questions I want you to answer. Is this a good supplement that you think you should support? And do you think that there's scientific evidence to support that? Why or why not? And I want you to state a hypothesis for how this might work. So if you think it's going to be efficacious, why? What's the mechanism it goes through? Or if you don't think, what's the reason you think it would not? Okay. And then the last part of that is I want you to design a study that scientifically tests if creatine is going to be effective. So what would be the optimal control group? What would be the design of the performance, for example? Would you do something that's a single long bout? Would you do repeated short bouts? Would you mess with the recovery time? All those kind of things I want you to think about. So I challenge you to go through that. As I said, we're not going to hand it in this time, but I'm tapping my nose here. That's a great exercise to go through. Okay, let's talk about another class of sort of ways we can cheat. These are absolutely ergogenic, and they're not really falling into dietary, but I think it's an important thing that we talk about. So anabolic steroids, when we think about steroids, this is really what we're talking about. So anabolic steroids are really the classification of synthetic derivatives of male sex hormones. So some derivative of testosterone.
It was such a big race. I mean,
Sorry, I'm gonna mess that up. There's a video there, which I'm really sorry that I can't show you these right now online. That's a video talking about the 1988 Olympics, which was a long time ago. But really what they're describing there is what's been called the dirtiest race in history. So it was the 100 meter, the flagstone of the Summer Olympic Games. And I guess some of you weren't, most of you probably weren't born. But go back and take a look at it. It was a big moment in Canadian history because a Canadian won. So before Donovan Bailey, we had this guy named Ben Johnson, who was an absolute beast. And it's really fascinating. When you go back and watch the video, watch the way he comes out of the blocks. He just absolutely explodes. And he's even compared to these other world-class runners. I mean, he's just massive. It relates to the topic because looking back, he was on all sorts of steroids. He was taking stanozolol. And if you go back and look at the story, Charlie Francis, who was his coach, was actually buying so much stanozolol from the supplier in the States that they had just incorrectly assumed that he must have been a veterinarian because they were selling him essentially horse steroids, which he was giving to his athletes. They worked, and it was a huge kerfuffle back then. So Ben Johnson won the 100 meters, and then it was stripped immediately because he failed the doping test. And just if you're interested, it's a really neat story that, as it turns out, every single runner in that race at some point tested positive for steroids. So yes, he was cheating. yes, so was everybody else. Shows you, I guess he was doing it better. And there's this sort of side story about one of the athletes sneaking in, and Ben Johnson said afterwards that, like, oh, my drink was spiked and that's why I tested positive. And there might actually be some truth to that, and that somebody actually did go in there and spike his drink. Now, he was taking them anyways, but that might have been why he got caught. If you're interested, there's a great ESPN 30 for 30 called 9.67, which is the time he ran it. And so anyways, if you're an exercise nerd and you want to look it up, it's a fascinating story, but it's all about steroids, and the steroids work. So there are all sorts of different steroids. So there are those that you can take orally, and there are those that are injected. But essentially, they have the same process. So interesting to talk about, okay, anabolic steroids, well, who uses them? I mean, I've given you an example of Olympic athletes, and I think when most people think about doping, that's what we think about, right, is anabolic steroid use. Interestingly enough, I mean, we look at last weekend's Super Bowl, right? The MVP of the Super Bowl served a ban for taking, well, undisclosed, but I would suggest likely anabolic steroid related. I mean, the guy's 5'0", 200 pounds, little ball of meat, which is an interesting thing, right? The NFL is notoriously weak on their testing, and perhaps that's a sociological debate, but can these athletes even sustain the punishment they take week in, week out without taking steroids? Part of me just thinks, I don't know, do we just accept that they're taking them and just move on? But the point I want to make here is that it's not just Olympic level or professional level or even collegiate level athletes. It's actually fairly widespread. I don't know if I want to say issue, but people use them for all sorts of reasons, and it's not just to perform at the highest level. Many people that use these have no involvement in sports at all, right? It's all about aesthetics and improving appearance and maybe shortcuts. No surprise, there are ergogenic benefits. It depends on how you'd want to use them. It doesn't mean that that's going to work for every athlete or that it even makes sense. Muscle mass and strength are the obvious things that are going to change. But if you're a kind of athlete that doesn't want to be bulky, increasing your protein synthesis and hypertrophy is not what you're after. Absolutely, changes can occur in both recreationally and trained competitive athletes, but training has to happen. It's not just that you take steroids and you turn into the Hulk. You have to cause that protein synthesis to occur. I guess the last bit I'd say on that, kind of an interesting point on this, there was a lot of kerfuffle in the scientific media recently about looking at what happens when we stop using our muscle cells. And basically it wasn't a debate, but what they were showing, and some people were all up in arms about, was when a muscle atrophies, that muscle cell doesn't just go away. And I guess that was kind of the belief for many years, that we've lost it and it's gone. Turns out it doesn't, and it still actually exists there, and you can turn it back on later. So it really suggests that when we look at training through the lifespan, well, being active at a younger age is probably really important, because we're more apt to be able to set ourselves up to have these muscles and then try to keep them over time, essentially, and turn them back on later because they don't really go away. If you read between the lines, though, it also has a huge implication for things like anabolic steroids. So, I mean, it's one thing to test an athlete and catch them using anabolic steroids when they're not allowed, and there's a lot of finger waving that goes with that. But really, the implication means if you're taking those steroids and that effect lasts for possibly the rest of your life, then you're just a fool if you get caught, because you should be doing that in a time where you can't be caught, assuming you don't have off-season testing, which now a lot of sports do, or random testing. But if you get away with it, then you could be off of that and still have these effects. And I should be careful what I say here. I'm not encouraging people to do the wrong things here by any means, nor would we promote this for our athletes. But that's actually true of a number of banned substances. We know some of these things also, like erythropoietin and steroids, their effects last long after. They can cause angiogenesis. They can cause these muscle cell growth that persist for at least months after somebody stops using them. So how are hormones, anabolic steroids specifically, how are these actually used? Typically, somebody that's on a program is going to use them in a stacking regimen. And what I mean by stacking is they're putting them together. They're not using one individual thing. They're using them to cause different effects, or they're combining them with other prohormones or things to get that effect. It's not just going to be one thing. The strength of any anabolic agent can be enhanced when it's put with another one. So if we're going through different pathways, we can kind of like the glucose fructose thing, right? We can have more of an effect if we've got more than one thing acting at the same time. The way the dosing patterns that these are used in, there's a bunch of different ways to do it, to be quite honest. The typical or the classic way to do this would be to cycle them. And essentially what I mean by cycling is there's sort of the macro cycle that you consider. So there's the on times and there's the off times. But within the on times, it's often done in a certain pattern as well. So one of those patterns could be something like using a pyramid. Okay, so a pyramid would essentially starts with a very low dose. And part of that is actually done for safety, to make sure that the body responds appropriately and safely, assuming that this is being monitored by appropriate medical professionals, which quite honestly, I don't believe it often is. If you log on to the bro science blogs, you will find all sorts of scary stuff on there about people with absolutely no background in this and no platform, or shouldn't have any platform, giving all sorts of advice. Some of it makes no sense too. But I mean, I logged on and just found this. So this kind of shows you this idea of stepping it up on the front side and stepping it down on the back side. So you can kind of go through this yourself. But this is essentially showing what would the effective dose be. So you can see each spike is going to be when some is given. Okay. If you go through this, you can see, so this is just one example that somebody put up there. The cycle, so every 6 days, something's happening, and you can see the injection amount starts off very low, and it gets higher and higher and higher until we hit this peak, and then it's going to be tapered off, and that's why it's called a pyramid. Okay, and then you can see the cumulative dose that it comes up with. I think it does make sense to sort of bring it through in a cyclical pattern. It makes sense in many training things, but as I said, they would do that for safety on the upside, and I understand on the downside. I've never done rounds of steroids, so I'm not speaking from experience, but it can actually be very psychological as well. It can be psychologically taxing because at the top here, you're He-Man, or She-Ra, or whatever. You're a superhero. Coming down the backside, you can't do the same things you did, okay? And your body is not reacting the same way. So things to think about. This is a dose response curve of anabolic steroids and what it does to lean body mass. And essentially what I want you to take from this is you can see the more you take, pay attention to the units here because it can be a little bit misleading. But as the dosages go up, changes in lean body mass go up. That's not saying that I think athletes should just pop in as much as they possibly can, but it's a clear dose response here. So the ergogenic benefits to athletic performance, again, some of these are quite obvious, okay? Increased muscle mass, strength. Interestingly enough, there's some new evidence that suggests that relationship between the amount of muscle mass and strength may not be as linear as we think. It's always just kind of been accepted that, well, yeah, people with bigger muscles are stronger. There's a few groups in the States right now that I'm aware of that are really trying to tease that apart, actually. They're trying to see if they can increase strength without increasing size at all, or vice versa, which is an interesting way. So they go in, they do things like they lift 1 RM one time. That's it. Day is done. And in doing so, you're not going to cause a whole lot of hypertrophy, but they have shown pretty massive increases in strength. Now, whether that persists beyond sort of the neural adaptation phase will be interesting to see. And they're starting to do this with pretty well-trained people to see if they can just keep strength going and sort of dissociate these things. So a bit of an aside, but interesting. And so all that just leads to athletic performance. Obviously, the efficacy is going to depend on who you're doing this with. If you're working with somebody like this that's probably been doing years of steroids already, or maybe they just naturally got that big, it's going to be harder to affect change, right? Because it's a baseline effect. I'll also point out, I believe this is a female on this side. Really, when you see female bodybuilders like this, I don't want to say it's completely impossible, but it is very unlikely that a female can put on that kind of muscle mass without the addition of some testosterone. So I guess the one possibility would be perhaps the binary classification of males and females is a little bit misleading. There are certainly some females who produce more testosterone than others. And if we consider it sort of a sliding scale, they would be maybe closer to the male end than other females in terms of the hormones that they produce and that their body reacts to. But in this kind of a case, that is probably not a natural response. I find it interesting. And it appears that the idea is going away a little bit maybe, but it used to be, many women were afraid to lift heavy weights because they didn't want to turn into a massively bulky female. And I'll put my wife into that category. I can remember many times saying to her when we go to the gym, you just got to lift heavy. You got to take it to fail. as a typical guy, I guess. And I know that was always a concern of hers, but the truth of the matter is that doesn't happen by accident, and it typically won't happen because there's just not enough androgens in the body to make that adaptation happen without injecting. So I talked a little bit about this idea of some of these things persisting after drugs have been used. And this is an interesting look here. So if you look on the left, you can see we're looking at increases in fat-free mass, so lean mass. Okay, and after 8 weeks of nandrolone use, so that is in a steroid, versus a placebo, you can see that in both cases, after 8 weeks of training, lean mass went up. These people put on muscle. But the increase in mass when you're taking a steroid is huge, right? It is, less than 1 kilogram compared to 2.5. But perhaps more interesting than that, if you look over 15 weeks after they stopped, what do we see? We can see that those effects still exist. Nandrolone is still much higher. So just one example of how that actually works. It has been suggested that anabolic steroids do have a lot of psychological effect. Roid rage, you may have heard it described as. It's interesting that the data, I mean, it's kind of mixed, if I'm quite honest about it. It might be that when you take testosterone stuff, aggression goes up, irritability, arousal. There's an alternative hypothesis that suggests there also may be a predisposition amongst people that take steroids. Maybe they are aggressive, aroused, irritable people to begin with. I don't want to overly stereotype here, but I think as an example, we can think about, let's be honest, guys with little dog syndrome, right? Guys with the big bark. And, you know, maybe the short guys, they've got something to prove. So maybe it goes hand in hand. Hard to say. It's a tough question to answer, whether it's a real thing or not. It does make some sense that we're jacking people up on this, but it's hard to pull apart the physiological from the psychological as well. There may be some adverse effects with anabolic steroid use. But again, if we're quite honest, it might be a little bit overstated. And I think if we step back from this and look at, you know, there are all sorts of reasons not to encourage steroid use. And I'm not against any of the programs that have been out there about keeping kids off drugs. I mean, I think that makes a lot of sense. And I don't think that steroid use should be promoted. And you talk about the NFL, right? I think that raises a really interesting sociological question. If you ask me as a physiologist, if it wasn't banned, does it kind of make sense for these athletes, and they do have weak testing procedures, does it make sense for some of them to be doing it just to recover between games? Yeah, it probably does. The steroids work? Yes, they do. And that's why they exist in medicine, and they're quite effective. But I think the interesting sociological issues come with, okay, so then if you want to go to the NFL and you're a 16-year-old kid, and we just say, hey, free reign, take whatever you want, and when do you start taking steroids? Is it okay to start taking them at 12 so that you're even more, quote unquote, prepared? I mean, I don't know where that goes. So that's an interesting thing. But some of those problems may be over exaggerated or could be dealt with. And some of them will disappear after use has gone down. And I'll go through, I'll show you what some of the side effects are, because they're real. And I'm not by any means suggesting that they don't matter, because they do. But I think the biggest thing is if it's done correctly. As I said, there's a role in medicine because those who understand how to use them properly can do so safely. The bigger issue is probably when we don't understand, we go, hey, a little bit of this is good, a whole lot of this might be better. Speaking of campaigns to stop people from using performance-enhancing drugs, I just like these. I think it is actually a pretty effective thing. I did work for the CCES, which is Canadian Center for Ethics in Sports, so doing doping testing. Whoops, sorry about that. And as you can see those, I think targeting a younger audience, that's pretty effective. So what are some of the effects associated with anabolic steroid use? You can see here, looking at the systems that are affected, it can affect many different systems in the body, right? Cardiovascular, which is obviously important, endocrine, or metabolic thing, certainly sex-based things, musculoskeletal, potentially psychological. So let's just go through some of these and maybe pick apart what they are. So cardiovascular, yes, there's some evidence that it may change lipid profiles, right? So when we look at a blood panel, we want good cholesterol. We don't want bad cholesterol, and it can move those potentially in the wrong direction. Blood pressure can be related as well. Myocardial function can be affected as well, in the way the efficiency of the heart contracting. Gynecomastia, which you may be able to think of less scientific ways to put that, but essentially males developing breast tissue. And part of that relates to the fact that if we're putting in testosterone, then the body starts to believe, hey, we've got good levels of this, we don't need to make it. So when we look at some of these sex-related things, it kind of makes sense from that perspective, that if the body's saying, hey, we've got high levels of testosterone already, let's just turn down function because clearly we're doing okay, then we might have issues. So decreased sperm count kind of makes sense. Testicular atrophy, ball shrinkage, for lack of a better way to put it, right? Because that's the role of this in the body, and it thinks it's doing a pretty good job, so it starts to tone it down. Impotence, transient infertility, all these things are related. Certainly links to the next one as well. You can think about why that affects males. That makes sense. Can affect females as well. And some of those issues that are going to happen in females are the exact opposite. So in a male, the signal the body gets is, hey, I'm doing great. I got all sorts of these male sex hormones. In a female, we have different effects where you have levels that wouldn't be expected. So absolutely that can affect menstruation. When you look at how a fetus develops, I mean, we all start the same. And really the thing that differentiates if you become male or if you become female is when testosterone is introduced. So in some ways, actually, our sex organs are very similar. Now, they develop differently. But if you start to add testosterone to that, we can have changes in that as well. Dermatological, these are the ones that kind of get put out there a lot. Acne or bacne in particular can be an issue. Male pattern baldness. Clearly, that's not the reason I'm bald, but it can affect that as well. Testosterone can affect all of these things. You can kind of go through the rest. Yeah, let's just move on from there. Okay, so that kind of covers our anabolic steroids. We can also talk about what we call is like prohormones, okay, or testosterone precursors. So rather than giving a testosterone derivative itself, we can actually give something that ends up leading to that, okay? It's kind of a neat idea, like just moving further up the chain. And as you can see there, performance changes may not occur with prohormone use, but athletes may use them anyways with the belief that they do, okay? Because they may have some effects that are similar. So HCG is an interesting one. HCG is commonly used. So when athletes male athletes in particular, if they start taking testosterone, as I said, it might downregulate androgens in the body to begin with. So one of the ideas is, what if we take these other things that are going to balance that out? So if we're getting too male on the one side, what if we just start injecting things that are going to make our body feel a little more female, if you will, and not turn off those signals? So we can stop testosterone being downregulated from endogenous sources because of the exogenous if we kind of trick it with something else. That's the idea. You may have heard of HCG before. Where? HCG is what is going to be tested in females in a pregnancy test. Yeah, so kind of an interesting idea. Other things that are used, insulin is commonly being used by weightlifters for a long time. And I think this is an interesting case of where basically the meatheads figured things out and the scientists were trying to catch up. And the idea here being, if we really want to promote muscle growth, well, then we need to make sure we're feeding those muscles. And some rather innovative bodybuilders back in the day figured out that, hey, you know how we can get more energy right in where we want it? Well, insulin's job is to tell it to store stuff, and the muscle is a great place to store blood sugars. So we'll get them in there. So these athletes would wake up and they'd microdose with insulin throughout the night as well to try and make sure that the muscles are being fed and we can increase protein synthesis. Obviously, a major risk of that is overdoing it, because if you get hypoglycemia, you can fall into a coma and certainly you can die as well. So it's not without risk, but it is perhaps a way to sort of fool the body into making sure we're recovering very well. Human growth hormone is something you've probably heard about. It gets a lot of attention. And the truth of the matter is there's not a lot of studies on human growth hormone. There's a lot of anecdote about whether or not it works and speculation. Mark Cuban, sorry, is the guy up there. He's taken a real interest in this because there's not a lot of evidence outside of medicine to suggest that this actually works to help athletes. So he's putting some of his own money into actually doing this. So time will tell. It'll be interesting to see what comes out of it. The anecdotal evidence does suggest that there may be big changes in musculoskeletal performance. Again, it may be one of those things that increases lean tissue, decreases fat tissue, potentially anti-aging. As I said, this is kind of like anabolic steroids, where we know from medicine that like it does all sorts of great things, and there are uses for this for sure. So it has potential as an ergogenic aid, but we have to see what it works. We need to think about, though, just because it works in medicine and in small doses, does that mean it's safe to be using or effective to be using with athletes? That's a pretty big jump. This is anecdote as well, but I'll just put this out there. There's potentially a risk if human growth hormone doesn't turn off. It can lead to a condition called acromegaly. And so this picture is sort of the typified expression of what happens when human growth hormone gets out of control. So you can see hands grow in a certain way, the knuckles keep growing, the nose keeps growing, the cheekbones and the forehead develop in a certain way. I'm not sure how many of you would remember Andre the Giant, but people that do have gigantism, and Andre the Giant was a professional wrestler turned actor, Princess Bride, if that's still a popular thing. I think he was in that. But you can absolutely see in somebody here who had the condition where he naturally had high doses of human growth hormone, he really did start to develop some of those things, a really big, wide jaw. I'm not suggesting any of these other people are using human growth hormone or maybe have the condition naturally, but there's certainly speculation that some of these well-known athletes or mixed martial artists or NBA players, if you go back and watch the video with Ben Johnson in The Dirtiest Race of History, this is Carl Lewis, he's a real mouthpiece, real arrogant guy who kept losing to Ben Johnson and claims he never doped, but there is evidence they did. But one of the things you notice is like there may be something that suggests, the use of human growth hormone. One of the interesting things, if you go back to that race, the 100-meter race, Carl and Ben and all those other guys in there, it's been suggested to be interesting that many of these athletes back in the 80s, when it was really quite dirty, had braces, all grown men. And so why did they have braces? Why did it look like their teeth were trying to run away from each other? So it suggested that because one of the effects of human growth hormone is to keep things like the jaw growing, essentially the head was growing and the teeth didn't know where to go with it. So they ended up kind of spacing out because the jaw just kept expanding. So they all got braces to try and bring their teeth back together. We certainly have to put into this category things like erythropoietin, right? So EPO is typically used less by strength athletes and more by aerobic type athletes. So erythropoietin is the signal that our body has when we get into conditions of low oxygen, for example, or if we're just not circulating enough, where we say, hey, we need to make more red blood cells. When erythropoietin came out, it was incredibly expensive because it used to have to be, you had to sort of mine it, if you will, from human donors and to extract it. And it was really an expensive thing to do. Since they came up with recombinant EPO, so man-made, it's become much cheaper and accessible. You'll buy it from China. But there are certainly health risks with this as well. I mean, we look back at the history of this. It has a notorious history in cycling. Anybody that followed the whole Lance Armstrong thing, this is one of the things they were doing, amongst others. But it's interesting to see. I mean, when it started there was a team of Dutch cyclists who realized that, okay, hey, this is kind of a cool thing when it came out. And they went, hey, a little bit of this is good. Let's take a whole bunch. And I think it was 6 members of the Dutch cycling team actually died, which is pretty sad. But essentially what they did is they turned their blood into sludge to the point that they had so many red blood cells and the plasma was their blood was so thick because the plasma level was relatively quite low that their heart had a real hard time keeping up. So crit goes up, hemoglobin goes up, sure, the capacity to move blood goes up, but eventually the heart just can't keep pumping it around the body. Rumor has it that back in the day when the Tour de France would come into these small towns in France, people would go crazy because in the middle of the night they couldn't sleep because all you hear is thump, 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 thump. Is these athletes who were all taking EPO would set their alarms, and they'd have to get up in the middle of the night and run up and down the stairs and run up and down the hallways in order to raise their their heart rate so that they didn't die in their sleep, because their blood was so thick. They really needed that injection of some exercise to keep things flowing. So an interesting thing, when EPO started being used as a tool for doping, it actually wasn't that hard to catch people, because all you had to do was withdraw some blood, and you can age a red blood cell. You can date sort of when it was born. The red blood cell lasts for about 120 days in circulation, and it starts as a reticulocyte, and then it develops into something later. So if you inject a whole lot of EPO, essentially you're giving, quote unquote, you're giving birth to all of these red blood cells about the same time. So you would expect, if you took out a little bit of blood and you looked at a histogram of when those were born, you should have a bunch that are young, a whole bunch in the middle, and a bunch that are old. If that pattern is skewed, it was pretty obvious to see that somebody changed something. Athletes, after getting busted for a while, figured out a way around that, as they typically do. And then what they kind of started doing was what's called microdosing. So, okay, we won't give a huge bolus that says like, hey, let's make more red blood cells now. So instead, it was a cycled thing where they take a little bit at a time. So a little bump, a little bump, a little bump, a little bump, until the whole thing came up. Now, what they do in doping to try and protect against this is they use something called the athlete passport. So they actually keep a record of what's normal for you, because there is variation between people. I mean, the reason that some athletes are really good is because they're born with high levels of androgens or high levels of EPO and thus red blood cells. So if that's normal for you and your passport supports that, that's okay. But when they see deviations, whether it be a real bump up or perhaps a real drop down, meaning you've always been doping and you shouldn't drop below your baseline unless something was removed that should have been there and you messed up, that's one way they're trying to combat this doping as well. EPO is the one side. Just out of interest sake, I'll tell you the other. And again, this is something that athletes have been doing for a while, and this involves blood transfusions. So this is kind of the old school way of blood doping, but it has been reinvigorated. Essentially what they used to do is they would find people with similar type blood, and rather than using EPO, which at the time was very expensive or not available, I'd find somebody that had the same blood as me and would take it out of you and put it into me, and thus increase my red blood cell count like that. That became pretty easy to catch as well, because you can figure out that they don't have the same DNA sequence, and you can look at them and say, you know, one is this guy's, the other one is this guy's, so you shouldn't have somebody else's blood in your veins. A real progression in that was, and actually my advisor, long before my time, had a role in figuring this out, but they realized they could take blood out of me, and the innovation was figuring out how to keep that blood viable, let my body compensate for the fact that I've lost that blood, bring my levels back up to normal, and then put that old blood back in. So it didn't work for the longest time because the blood cells were exploding in the freezers, or they were dying, and thus they were not viable. But essentially when they figured out how to wash them and store them and then put them back in, we'd sort of solved that problem of, you can't tell, it's not somebody else's blood, it's my blood, and they're all normally distributed. So that became a real thing. And just to sort of finish that story, when the whole thing broke about Lance Armstrong's team, that was one of the things that these guys were doing, which is crazy to me, is they would finish a stage, get on the team bus, and while they were driving to the start of the next stage, they would actually string up blood bags, lay in the aisle of the bus, and reinfuse blood back into themselves so they'd recover and be ready to go for the next day, which is kind of nutty. So it's a thing. It's out there for sure. EPO is kind of the easier, cleaner way to do it, if you will, but there are all sorts of ways that blood doping can be accomplished. We can also talk about beta-adrenergic agonists. Interestingly enough, I just recorded a lecture for my other class talking about these types of things in beta blockers. And these are typically used in medicine to either crank up the system, because an agonist is actually something that it's a sympathomimetic. So it's like we have this sympathetic impulse that's saying, like, it's like epinephrine or norepinephrine, right? It's telling everything, hey, let's crank it up, kind of like ephedra. These can be used, again, if we're cranking up metabolism, they could be used to increase lean mass and decrease fat. So that's the one side. And on the other side, we've got things like beta blockers. And beta blockers would do exactly the opposite. So if we're thinking of somebody with like heart failure or hypertension, these might be given to sort of calm the whole system down, right? Lower heart rate, chill it all out. This one is certainly surprising to me. I hadn't thought about this. But there are some sports, archery might be an example, biathlon, apparently this is a bit of a thing as well, where they have to stop and shoot. And it's really to calm everything down. so that they can shoot between heartbeats. And so that they don't have tremors and stuff like that. Now, obviously, in sports where there's an aerobic component like biathlon as well, there would be a balance between this being effective or not effective, because it will affect max heart rate and thus cardiac output. Key point. Okay, more research is needed. And I think that's going to be true. And truthfully, even when we get all of these things that I talked about figured out, there will be more and there will be new ones. And I find it an interesting dance between the scientists trying to catch the cheaters and those who are innovating and coming up with new ways to beat the tests. But I think it's important to point out that, some of these things work, yes. Some of them carry notable risk with them. And I really want to point out that just because something may appear safe, just because we don't have the data to suggest it's dangerous, doesn't mean that it's not. Okay, so this I'm actually going to skip through. This is a sort of a case study here on L-carnitine. Just in the interest of the fact that this is a recorded lecture, I'm actually going to go through this, and we're going to go through one of the other ones. But this, I will give it to you. You can certainly go through it yourself. Looking at just a little bit more of a deep dive on L-carnitine. So you have these slides. What we are going to talk about is antioxidants. I want to spend a little bit of time talking about that. So antioxidants, I think, are something that we've all heard of. Very, very common, whether it be from a recovery point of view, from athletics, or even just this is something that many people take kind of in their own lives and preventatively. So I'll point out that antioxidants really come from, I think the use of antioxidants comes from medicine, and it comes from this idea that it was discovered many years ago that when people have high oxidative stress and they have chronic inflammation, that's associated with bad things, bad health, and that's a fact. And if those are happening for reasons that are not going to go away, for example, and it's not something like training where we intentionally do that so the body will adapt, then that might be an issue, and that's stressing the body, and it's constantly stressing the body, and it needs to be dealt with. I find it interesting that I think that sort of rationale from medicine has been pushed over into sport and into trying to live a healthy lifestyle. So the whole idea here with using antioxidants is to prevent reactive oxygen species. So these are naturally occurring things that happen as a byproduct of oxidative metabolism. So when we exercise and oxidative metabolism goes up, then naturally reactive oxygen species go up as well. Okay, and the whole idea here, again, being that if we see chronic levels of ROS being high, well, it wreaks havoc on the body, then that must be a bad thing. We want to avoid that. Okay, so the idea when we take it to athletes is, could athletes then, if they're cranking up levels of ROS, if they take more antioxidants, knock down the free radicals, are they going to improve their recovery? Okay, so let's take a look at this. Can antioxidants prevent the health benefits and muscle adaptations known to occur following exercise training? Here's a study. 20 people in each group, 20 trained, 20 untrained. And they did 4 weeks of exercise training. Okay, so half of each group had antioxidant supplement. In this case, they used vitamin C and vitamin E, which are pretty powerful antioxidants. Okay, the other ones received a placebo. They did pre-post, okay, and they measured things. We'll talk a little bit about how an insulin clamp works, okay, but they're looking at insulin sensitivity, so their ability to deal with sugar, if you will, and they looked at a number of key proteins and signaling markers. So what do we see here? On the left, we've got in our untrained people. On the right, we've got our pre-trained people. So let's start over here on the left, broken into the group that did not supplement and the group that supplemented with vitamin C, vitamin E as an antioxidant. So glucose infusion rate tells us how much glucose can we put in, and that's a good thing. Okay, so that means we can give the body more glucose and it's able to deal with it in a good way. So what we see here is in the group that did not supplement, the white bars show where they started, the gray bars show where they ended up, and we can see there's an improvement there, and the glucose infusion rate went up. They're able to deal with sugar more effectively when it's given. Interestingly, when we look at the group that took vitamin C and vitamin E, we can see here they did not see that training-related response that would have been expected. So this is our control. We went, yep, that's the thing that should happen. Suddenly give antioxidants. That does not happen. When we look at the group that was already in better shape, so they weren't noobs, if you will, same effect, right? We can see, yeah, these guys trained, so everybody started at a higher level, okay? But if you trained, you still went up. However, if you took high-dose antioxidants, that effect didn't happen. So antioxidant supplementation, it actually prevents an improvement in insulin sensitivity, which would be a good thing. It's a good thing, as we talked about, why are bodybuilders taking this? Because you want insulin to work. You want that for recovery. So that's interesting. Let's look at PGC1 alpha. So there's our typical regulator of mitochondrial biogenesis, right? And we see the same effect. So in the control group, when they exercise trained, PGC1 alpha goes up. In the group that was taking high-dose antioxidants, it's definitely blunted. Okay. When we look over here in the pre-trained, same effect, and it's blunted so much in the antioxidant group that it doesn't even seem to occur. Last one, so SOD2, okay. This is an enzyme that helps stop the bad effects of ROS, if you will, okay. We want this to go up. We see in the control group that exercise training will cause that. Doesn't happen with antioxidants, whether you are trained or untrained. So an interesting thing, and I'll point out that's just one study, but there's been a number now that's sort of shown that same thing. It's been shown in cardiac rehab patients, for example. In that case, again, they use vitamin C, vitamin E, which I find there are other things we could give people, resveratrol, whatever else it might be. But I mean, when you take just typical over-the-counter vitamins in fairly high doses, and that's something that people commonly do. And they showed in these cardiac rehab patients that VO2 was blunted as well. So these old guys that were in the study that would really benefit from increasing their fitness didn't. They essentially stopped that effect that they were trying to train from happening. So what do we see? Well, it may be that antioxidants kind of impede on this pathway here. To suggest that maybe what we really do is when we exercise, yeah, we do increase oxidative stress, but maybe that's a good thing because maybe that's the signal that tells the body, hey, we're not good enough at this, or like we worked hard at this, we need to get better. Thus, PGC, SOD, all these other things, insulin sensitivity go up, okay? Thus affecting whether it be disease risk, as shown in this one, or it could even be performance, training adaptation. So the take-home message, free radical production and likely inflammation as well is likely necessary to stimulate adaptations in response to exercise. If you take high doses of antioxidants, and I'm going to show you some data on inflammation as well, it could interfere with this. Basically, the body is going, I think we're good. We're going to turn off that signal. I don't want to spend too much time on this because I appreciate this is not the best way with a recorded lecture, but I do want to talk about this a little bit. This is a study. We never actually published it, but it was kind of a neat one where a supplement company came to us, and they had this substance up here called curcumin. So curcumin is, if you look it up, it's a wonder drug, according to everybody online. But it is a powerful antioxidant and anti-inflammatory. And that's a fact. And so they came to us and they suggested that maybe this would be a good supplement for use with athletes. So let me quickly walk you through what we did here. I thought this was kind of a neat design. Well, of course we did because we did it. But we had people come in, okay, we figured out who they were, whatever. And then we had them do 2 different bouts, one here and then another one later, okay, where we put them onto a treadmill like this. In fact, it was actually that treadmill. And we ran them downhill. If you've never run downhill before, it's hard. So we ran them at 60% of VO2 max, which is not very hard exercise, but at a 12% decline. And very quickly, your legs start to feel like Bambi. You get all wobbly, and it's really hard. And we did that for an hour. And essentially, what happens when we do that is we beat people up pretty good. And you could tell who'd been in our study because they were limping all over campus for a while after. We had them come back into the lab. We did a whole bunch of measures on them when they came back in. But we tested them before they started. We ran them downhill, and then they came in a day later, 2 days later, 3 days later. And we kind of looked at what's going on with that response. We looked at what's happening with their vasculature, what's happening with measures of muscle breakdown, what's happening with inflammation, and what's happening with their ability to perform. So let's kind of walk through that. Oh, sorry. So we did that here. Then what we did is we put them into 2 groups. One got the curcumin. The other got a placebo. They took that for 7 days, and then they did the test again. And we said, okay, so if the first one was, okay, you went out and did your thing, this is training, then you recover, you're going to go out and train again. how are you going to respond to that? Here's what we found. So you can see here, this is looking at creatine kinase, which is a measure of muscle breakdown. Okay. And essentially they're about the same, right? Because in the first time we did it, nobody had been treated with anything. You can see there was a little bit of a difference in that the experimental group, they might have had a little bit more muscle breakdown, not a whole lot, but essentially the same response, same pattern. Okay. In phase 2, we can see, if anything, the placebo group had a little bit more breakdown. And so maybe we started to blunt that creatine kinase response. The creatine kinase is a commonly used marker of muscle breakdown, and it basically is showing up in the bloodstream, and it shouldn't be there otherwise unless cell membranes are being broken apart. But one of the challenges with that is we actually don't know what specific isoforms we're measuring. It's just a general thing. Okay, it went up. So we look at that and go, well, that's interesting. It might be actually that this is effective for stopping muscle breakdown, because we used it for 7 days, and that level seems to have gone down. The pattern switched a little bit. Funny enough, when I was analyzing this data, it was a double-blinded study, so I didn't know what group was what, but I was pretty sure I had it figured out, certainly by this point. And then we looked at muscle soreness, or delayed onset muscle soreness, DOMS, to see what happened. And this is where everything got all messed up. And I was really surprised when I broke the blind. Here's what we saw. So this is phase 1. We can see, kind of makes sense that the group that had a little bit more evidence in their blood of muscle breakdown suggested to us that it hurt a little bit more. So maybe they weren't quite as smooth in their running, or whatever it was. We actually caused a little bit more damage. When they came back, this is where things got really interesting to me. So you can see here, we look at the blue line first. So this is our placebo group. So they really did nothing except run once, take a break, come back and run again. Okay. And this is sort of the typical response we'd expect. It's like when you go to the gym in January, your New Year's resolution, you haven't worked out, but you're all motivated and pumped up to do it. So you work out way too hard to get really sore. Typically, you can't get that sore again, right? Because we call it the repeated bout effect. You're protected from that in some way. So that makes sense that they kind of went down the second time. Interestingly, though, if you look at the experimental group, they reported a fair bit of pain the first time, and they also reported significantly more pain the second time. So whatever it was going on in their body, we basically stopped that signal and said, hey, you should adapt to this. It's almost like we tricked the body into saying, like, oh no, we knocked down all that inflammation and all those reactive oxygen species. You're good. You don't need to change anything. And so they didn't. And so that was a really interesting finding to us. Just another example of how interfering with the body's natural process of adaptation may affect things. Okay, so assigned readings. Originally, the assigned readings for this were Tarnopolsky and Cribb. They're not going to be. I've changed it a little bit. If you're not offended by the language, I do encourage you to watch the John Oliver video. I think that's a really good one. I've actually posted 2 other readings, which I think are very applied and really good. So the IOC consensus statement is pretty new and just came out. And Dr. Trent Stellingwerff has also published a thing about looking at what supplements work and how should they be used. It's a very applied reading. So those are the readings for this week, and I have put them up online so you can access them. I've actually put the whole article up, and you can find it in the content. So the use of natural health products, costs and benefits. I want to suggest it is absolutely important to think through the process of how a natural health product is proposed to work. Most will not, because you simply can't fool the body. Absolutely, when we're working with our athletes, we want to think about how something's supposed to work, what's the magnitude of the effect, what's the risk we're taking on. And when we think about sort of the risk or the cost, that might be financial. There are some things that could actually make athletes worse. Are we affecting their performance or their health? Are they going to test positive for something? Is it a clean supplement? Is it something they should be taking? Is it verified? And so those are all the kind of things we really do want to think about. With that, thank you for your attention today. Again, I apologize that we had to do this over video, but I hope that this worked and got you through the material. Good luck in your studying. If you have questions, please feel free to reach out to myself, the TAs. And if there are questions, let's hit the discussion board if we can so everybody can benefit from them, or I will put up announcements to bring that to everybody's attention. Have a great day, and we will see you next week ready to go for the exam.